Hey everyone, and welcome to this clinical review. Today, we're zeroing in on a critically important chapter in perinatal medicine. Consider this explainer your absolute high-yield board review on perinatal viral transmission. Specifically, we're talking about the torch pathogens. We're going to break down exactly what you need to know so you can recognize and manage these threats like a pro. Okay, let's dive right into this. Picture this. You're out there on the wards. You grab a patient's chart, and you see unexplained intrauterine growth restriction, maybe non-immune hydrops, or oligohydramnios. So, what should instantly trigger your clinical suspicion? Ding, 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 it's the torch infections. Here's our quick roadmap for today's clinical pathway. First up, the baseline torch threat. Second, toxoplasmosis and rubella. Third, cytomegalovirus and HSV. Then we'll tackle the other infections. And finally, we'll bring it all together with exact diagnostics to really empower your decision-making on the floor. All right, Section 1, the torch threat. Before we get into the nitty-gritty specifics, let's establish the baseline danger here. Why do we even group these specific pathogens together in the first place? Well, it's because when a mother acquires them during pregnancy, they all share this unique and, frankly terrifying, ability to cross the placental barrier. Breaking down the classic acronym, we've got T for toxoplasmosis. O is for other, which wraps up syphilis, varicella, parvovirus B19, and Zika. R is for rubella, C is for cytomegalovirus, or CMV, and H is for herpes simplex virus, or HSV. The absolutely crucial thing to burn into your memory for your exams, and honestly for your future patients, is that these exact bugs can cause massive fetal morbidity or mortality. Moving on to Section 2, toxoplasmosis and rubella. Let's talk first trimester risks. Now, what's really interesting here is the toxoplasmosis timing paradox. You probably already know that toxoplasmosis is typically acquired from infected cat feces or maybe undercooked meat. But think about the timing for a second. The risk of transmission actually peaks at 60%, way late in the third trimester. However, the risk of severe fetal damage is the exact inverse. The damage risk is highest, also at 60%, if the infection happens early in the first trimester. So more transmission happens later, but much, much more severe damage happens earlier. Okay, get your flashcards ready because these are your rapid-fire board buzzwords. For toxoplasmosis, you need to instantly associate it with FGR, hydrocephalus, microcephaly, intracranial calcifications, and chorioretinitis. Boom. Then we have rubella, also known as German measles. Rubella is a wildly potent teratogen, and it's especially dangerous during first trimester organogenesis. An infection in those first 12 weeks often leads to congenital rubella syndrome. The key clinical buzzwords to lock in are sensory neural deafness, cardiac anomalies like PDA and septal defects, cataracts, and a cloudy cornea. Because congenital rubella syndrome is just so devastating, prevention is the name of the game. But here is a hard and fast clinical rule you absolutely must remember. The rubella vaccine is a live attenuated virus. Because of that, it is strictly contraindicated during pregnancy. No exceptions. Prevention literally has to happen before the patient becomes pregnant. All right, Section 3, CMV and HSV. It's time to shift our timelines. Shifting our focus to the C and H of the acronym, let's contrast these two vulnerability timelines. As we just discussed, rubella is incredibly dangerous early on during first trimester organogenesis. But CMV, it plays by a totally different set of rules. CMV can damage fetal organs throughout the entire gestation. And this brilliantly illustrates why CMV is such a massive, pervasive threat. It's actually the most common cause of congenital viral infection, precisely because that window of vulnerability never actually closes. Now, is there a silver lining? Sort of. Keep the number 10 in mind. Only about 10% of CMV-infected fetuses actually suffer serious damage. But for that 10%, the clinical picture is incredibly severe. We're talking affected neonates showing intracranial calcifications, hepatosplenomegaly, thrombocytopenia, sensory neural deafness, and mental retardation. Now let's tackle the HSV, herpes simplex virus. Looking at its clinical profile, the highest risk timing is actually a primary infection in the last trimester, which can trigger premature labor or FGR. But pay close attention to the mode of infection here. Transplacental infection is super rare for HSV. Instead, the fetus is almost always infected by virus shedding in the birth canal during delivery. If transmission does happen, the neonatal complications are disseminated and very often fatal, severely wrecking the brain, lungs, and liver.
So the crucial point boils down to this obstetrics golden rule. If your patient has active primary genital lesions at term, that is a standard, non-negotiable indication for a cesarean delivery. You absolutely must bypass that birth canal to prevent a fatal neonatal transmission. It's a simple intervention, but it literally saves lives.
Section 4, the other infections. We're talking syphilis, parvo, and Zika. So we're going to look at the modern additions, grouped under the O in TORCH. These are pathogens that have increasingly stolen the spotlight in perinatal medicine. Here are your rapid-fire high-yield associations. First up, syphilis, caused by Treponema pallidum. This can cause miscarriage, macerated stillbirth, or non-immune fetal hydrops. But for late congenital syphilis, you absolutely must link the terms Hutchinson teeth and saddle nose straight to this pathogen. Next is parvovirus B19, which gives you severe anemia, high-output cardiac failure, and non-immune hydrops fetalis. Finally, Zika virus, which is a more recently recognized teratogen. Connect Zika directly to microcephaly and severe ocular anomalies. I want to pause on parvovirus B19 for a second to explain the underlying pathophysiology, because once you get this, the clinical presentation just makes total logical sense. The virus primarily targets fetal erythroid precursor cells. When it attacks those cells, it basically just halts red blood cell production entirely. No red blood cells, you get severe anemia. The fetal heart tries to compensate by pumping way, way harder, which leads to high-output cardiac failure, and that ultimately results in non-immune hydrops fetalis. It's like a domino effect. When you understand that mechanism, the symptoms are unforgettable.
And finally, Section 5, diagnostics and suspicion. Let's talk clinical workups.
This brings us to the real climax of our explainer. We've talked about all the mechanisms and the buzzwords, sure, but how do you actually diagnose these threats when you're face-to-face with a patient? The tricky thing about TORCH infections is that routine screening isn't always recommended. For instance, we don't just routinely screen everyone for CMV. Because of that, specific clinical and ultrasound findings have to be your trigger for action. You have to maintain a really high index of suspicion if you encounter a fetus with unexplained intrauterine growth restriction, non-immune hydrops, oligohydramnios, or specific ultrasound findings like ventriculomegaly, which remember points towards CMV. Let's see how this builds into your definitive diagnostic algorithm straight from the clinical guidelines. Step 1. Identify those clinical or ultrasound triggers we just talked about, like FGR or hydrops. Step 2. Test the maternal serum for IgM and IgG antibodies so you can check for recent or past infection. And Step 3. Perform a PCR of the amniotic fluid. That confirms the actual presence of the pathogen in the fetal environment. It's a clear 1-2-3 process. So here is my final thought and a challenge for you. When you see unexplained FGR on the wards tomorrow, how are you going to apply this diagnostic pathway to protect your patient? Keep these clinical features, these shifting timelines, and these concrete diagnostic steps front and center as you head into your rotations. Thank you so much for joining me for this explainer. Study hard, trust the structure, and I will see you next time.